Good afternoon, dear students. The topic of our lecture is differential diagnostic of endocardium and myocardium lesions. Endocarditis is an infection of the lining of the heart chambers and heart valves that is caused by bacteria, fungi, or other infectious substances. Infective endocarditis is the disease in which clinical manifestations are due to infectious inflammation of the lining of the heart chambers, heart valves, and great vessels. Nosocomial infectious endocarditis manifests 48 hours after the patient is hospitalized or associated with a procedure performed within 4 weeks of the beginning of the disease, for example, due to the placement of intravascular line or developing in previously damaged valve. Causes of endocarditis are bacteria, Staphylococcus aureus, Staphylococcus viridans, Enterococcus, fungi, medical procedures. Risk factors: artificial heart valves, congenital heart disease, atrial septal defect, heart valve problems such as mitral insufficiency, history of rheumatoid heart disease. Symptoms of endocarditis may develop slowly in subacute or suddenly acute. Fever. Other symptoms may include abnormal urine color, blood in the urine, chills, excessive sweating, fatigue, joint pain, muscle aches and pains. Nail abnormalities, finger hemorrhage under the nails, night sweats may be severe, paleness, red, painless skin spots on the palm and soles, Lenawee lesions, red painful nodes, osseous nodes in the pads of the finger and toes, shortness of breath with activity, swelling of feet, legs, abdomen, weakness, and weight loss. Modify due criteria for the diagnosis of infective endocarditis. Define infective endocarditis. Pathologic evidence of intracardiac or embolized vegetation or intracardiac abscess, or clinical criteria: 2 major or 1 major and 3 minor or 5 minor criteria. Possible: 1 major and 1 minor or 3 minor criteria. And rejected: FEM alternate diagnosis. Infective endocarditis syndrome resolved within 4 days of antibiotic therapy. No pathologic evidence of infective endocarditis at surgery or autopsy within 4 days of antibiotic therapy. Case doesn't meet possible infective endocarditis criteria. Modified due criteria, the clinical criteria also. Major criteria: it is possible blood culture, positive blood culture, positive echocardiogram, vegetations, paravascular abscess or valve dehiscence, or after surgery, new valvular regurgitation by auscultation, not by echocardiogram. Minor criteria: predisposing heart condition, including prior infective endocarditis, injection drug use, fever, major arterial emboli, septic pulmonary infarcts, necrotic aneurysm, intracranial hemorrhage, or conjunctival hemorrhage. Minor criteria also are Genevieve lesions, glomerulonephritis present, osseous nodes, painful lesions at fingers tip, rod spots, retinal hemorrhages, positive rheumatoid factor, single positive blood culture, serologic evidence of active infection with an organism consistent with infective endocarditis. Exams and tests. The healthcare provider may hear abnormal sounds called murmurs when listening to the heart with a stethoscope. A physical exam may also reveal physical exam, Springer hemorrhage in the fingernails. An eye exam may show bleeding in the retina, a central area of clearing. This is known as rod spots. Blood culture, chest X-ray, complete blood count, CT scan of the chest, echocardiogram, ultrasound of the heart, erythrocyte sedimentation rate, ESR, transesophageal echocardiogram. Clinical manifestations. First one, intoxication syndrome. Fever in 85 to 92 of persons of patients. Heptic type is most common for Staphylococcus escherichia coli, chills, perspirations, arthralgia, myalgia, and loss of appetite. It is symptoms of intoxication syndrome. Hemorrhagic diathesis, petechia, sublingual hemorrhages, splinger hemorrhages under the nails, hemorrhagic retinal lesions, subarachnoid hemorrhage from rupture of mucotic aneurysm. Embolism of different locations can be present, including transient ischemic attacks, kidneys, heart, lungs, spleen, etc., sometimes with development of abscesses, apostomatous nephritis, acute septic monoarticular arthritis, and purulent meningitis. Auscultation signs of wealth insufficiency. Sometimes acute manifestations may be present. Heart failure with the signs of congestion in pulmonary or and systemic circulation, vasculitis, Genere lesions. Most other hypotenor eminences of the hands and feet usually represent an infectious vasculitis. Osler notes smallish tender nodules that range from red to pale located in the phalanx of the fingers and toes, soles of the feet, tenor and hypotenor eminences, often preceded by neuropathic pain, last from hours to several days. Non-infective vasculitis due to the immune complexes. Other autoimmune disorders, such as arthritis, usually asymmetrical with or from 1 to 3 joint affection, Ressemblance rheumatoid arthritis, Reiter syndrome, Lyme disease, the fluid is usually sterile, splenomegaly and hepatomegaly is present. Fingers and toes clubbing in case of prolonged coughs. Treatment. Admitted to the hospital, high-dose antibiotic treatment is needed to get rid of the bacteria. Treatment is usually given for from 4 to 6 weeks, depending on the specific type of bacteria. Surgery may be needed to replace damaged heart valves. Prognosis. Early treatment of bacterial endocarditis generally had a good outcome. Heart valves may be damaged if diagnosis and treatment are delayed. Complications. Blood clot or emboli that travel to brain, kidneys, lungs, or abdomen. Brain abscesses, congestive heart failure, glomerulonephritis, jaundice, neurological changes, rapid or irregular heartbeats, including atrial fibrillation, severe valve damage, and stroke. Pericarditis can be idiopathic, viruses, bacteria, tuberculosis, HIV, metabolic illnesses, kidney failure, uremia, and hypothyroidism. Symptoms of pericarditis. It is usually chest pain. Patients feel worse when lying flat. Other symptoms may include fevers and chill sweats. Shortness of breath, difficulty swallowing. Diagnostic. History and physical examination. Diagnostic testing. ECG. The ECG may be normal. Chest X-ray is usually normal. However, if fluid accumulates in the pericardial sac, the heart can appear larger on the X-ray echocardiography. Treatment. A viral infection and the treatment is aimed to decreasing inflammation and controlling pain. Non-steroidal anti-inflammatory drugs, pericardiocentesis, pericardiotomy, and pericardioectomy are the treatment options in case of pericarditis. Myocarditis. Definition. Myocarditis, also known as inflammatory cardiomyopathy, is inflammation in the heart muscle. Causes. Myocarditis is an uncommon disorder that is usually caused by viral, bacterial, or fungal infections that reach the heart. Viral infections: Coxsackie, cytomegalovirus, hepatitis C, herpes, HIV, parvovirus, bacterial infections such as chlamydia. Causes: Mycoplasma, Streptococcus, Treponema, fungal infections, Aspergillus, Candida, Cryptococcus, etc. Allergic reactions to certain medications or toxins, being around certain chemicals, certain diseases that cause inflammation through the body. Rheumatoid arthritis. Symptoms. There may be no symptoms. Symptoms may be similar to the flu. If symptoms occur, they may include abnormal heartbeat, chest pain that may resemble a heart attack, fatigue, fever and other signs of infection including headache, muscle aches, sore throat, diarrhea or rashes, joint pain or swelling, leg swelling, shortness of breath. Other symptoms may occur with this disease. Fainting, are they related to irregular heart rhythms, low urine output. Exams and tests. A physical examination may show no abnormalities or may reveal the following: abnormal heartbeat or heart sounds, murmurs, extra heart sounds, fever, fluid in the lungs, rapid heartbeat such as tachycardia, swelling, edema in the legs. Tests used to diagnose myocarditis include blood cultures for infection, blood tests for antibodies against the heart, muscle, and the body itself, chest X-ray, electrocardiogram, heart muscle biopsy, endomyocardial biopsy, red blood cell count, ultrasound of the heart, echocardiogram, and white blood cell count. Pathophysiology of myocarditis. The cause of viral myocarditis is characterized by three phases. It is acute phase, it is subacute phase, such as immune response, and chronic phase, the formation of dilated cardiomyopathy. So, 10 days after viral infection, it will be immune response or the formation of subacute phase of myocarditis. And then after 1 month up to 3 months, it will be formation of dilated cardiomyopathy. The ECG findings in patients with myocarditis vary from non-specific T-wave and ST segment changes to ST segment elevation, mimicking an acute myocardial infarction. Also, atrial or ventricular conduction delays as well as supraventricular and ventricular arrhythmias can occur in patients with inflammatory heart disease. The presence of Q waves or a new left bundle branch block are associated with a higher rates of cardiac death or heart transplantation. You can see an example of electrocardiogram of the patient with myocarditis, and it looks like myocardial infarction. As you see, it's necessary to differentiate with myocardial infarction. The same situation. Classical appearance ECG myocarditis simulating a myocardial infarction. Echocardiography. There are no specific echocardiographic features of myocarditis. However, echocardiography allows the evaluation of cardiac chamber size, size and wall thickness, as well as systolic and diastolic function in patients with myocarditis. Patients with fulminant myocarditis often have normal cardiac chamber sizes with an increased septal thickness secondary to acute myocardial edema, whereas patients with acute myocarditis have marked left ventricular dilation and normal wall thickness. Cardiovascular magnetic resonance (CMR) imaging has evolved as a non-invasive and valuable clinical tool for the diagnosis of myocarditis. Endomyocardial biopsy is the gold standard in diagnosis of myocarditis. According to the Dallas criteria, acute myocarditis is defined by lymphocytic infiltrates in association with myocyte necrosis. Borderline myocarditis is characterized by inflammatory infiltrates without evidence of uh, myocyte necrosis. The Dallas criteria are limited by the high interoperability in interpreting biopsy specimens, in particular with regard to borderline myocarditis, and because non-cellular inflammatory process cannot be detected. Dallas criteria introduced in 1986 for pericarditis and based on endomyocardial biopsy specimens. Active myocarditis, according to these criteria, is if light microscopy revealed infiltrating lymphocytes and myocytosis. Borderline myocarditis or ongoing myocarditis if lymphocyte infiltration and no myocytolysis, and negative for myocarditis if no lymphocytic infiltrate and no myocytolysis. Dallas criteria introduced in 1986 for pericarditis. It based on endomyocardial biopsy specimens. Active myocarditis if light microscopy revealed infiltrating lymphocytes and myocytolysis. A borderline or ongoing myocarditis if lymphocyte infiltration and no myocytolysis. Negative for myocarditis if no lymphocytic infiltrate and no myocytolysis. Treatment is aimed at the cause of the problem and may involve antibiotics, anti-inflammatory medicines to reduce swelling, diuretics to remove excess water from the body, low salt diet, and reduced activity. Specific treatments, specific types of myocarditis based on autoimmunity and treated with immunosuppressions, for example, in patients with giant cell myocarditis or cardiac sarcoidosis. In case of giant cell myocarditis, combined treatment with immunosuppressants, for example, cyclosporine and corticosteroids with or without azathioprine or moronomab CDS may improve the poor prognosis and yield median survival time of 12 months compared with 3 months for in untreated affected patients. Nevertheless, a minority of patients require mechanical circulatory support of heart transplantation within 1 year. Physical activity in acute myocarditis, avoidance of aerobic physical activity is indicated in addition to pharmacological therapy. In patients with stable heart failure, after a previous history of myocarditis, physical exercises are recommended. Patients, talking about prognosis, patients with acute myocarditis are preserved left ventricular ejection fraction and preserved left ventricular ejection fraction have a good prognosis with a high rate of spontaneous improvement without sequelae. In patients with cardiac sarcoidosis or giant cell myocarditis, prognosis depends probably on an early initiated treatment, immunosuppressive therapy, or heart transplantation. Treatment for myocarditis may include corticosteroid therapy to help reduce inflammation, cardiac medications such as beta blockers, AC inhibitors, behavioral changes such as rest, fluid restriction, and low salt diet, diuretic therapy to treat fluid overload, and antibiotic therapy. Possible complications of myocarditis are cardiomyopathy, heart failure, or pericarditis. Possible complications include the sudden loss of consciousness, syncope, abnormally fast, slow, or irregular heartbeats, the so-called cardiac arrhythmias. And thank you for your attention.